Hi, today we talk about obstructive pulmonary disease, and it's a bronchiectasis. It's a specific changes in the lungs, which you can see by using CT scan or chest X-ray. Also, asthma, and there are three classical symptoms. It's a cough, wheezing, and shortness of breath. Also about COPD, chronic obstructive pulmonary disease. It's emphysema and chronic bronchitis, and in many cases, the cause of this condition is smoking. So many patients with COPD have history of smoking, but not all people who are smoking can have COPD, just 10% of these people. And we also talk about cystic fibrosis. It's a very severe condition, and survival rate is just 31 years, and it affects many organs and system due to defect of ion channel protein. So let's get started. Bronchiectasis is a disease in which there is a permanent enlargement of parts of the airway of the lungs. Predisposing causes include whooping cough, measles, TB, tuberculosis, inhaled foreign bodies, for example peanuts for kids, bronchial carcinoma, cystic fibrosis, and congenital ciliary dysfunction, or Contaginer syndrome. And clinical features: chronic cough, worse on walking. For mild cases, yellow or green sputum, especially after infection. For advanced cases, profuse purulent offensive sputum, persistent halitosis, recurrent febrile episodes, and malaise, weight loss. Also, episodes of pneumonia, hemoptysis, could be blood-stained or massive. On examination, you can see coarse crackles over infected areas. Diagnosis: chest X-ray, normal or bronchial changes, sputum examination for resistant pathogens and to exclude TB, cytology to rule out neoplasia. So the gold standard for diagnosis bronchiectasis is CT scan, and it can show bronchial wall thickening. Main pathogens: the most common is Haemophilus influenza, and also could be Streptococcus pneumonia, Pseudomonas aeruginosa, and Staphylococcus aureus. Treatment: postural drainage, antibiotics for acute exacerbation, and usually according to organism, it's usually amoxicillin. And if there is evidence of bronchospasm, bronchodilators. Asthma, and it tends to develop between the ages of 2 and 7 years, but can develop at any age, and most children present with a cough, and also they usually free from it by puberty. Causes of asthma: it's allergens like pollens, animal dander, dust mites, mold, bronchial infections, cold air, exercise, drugs like aspirin, NSAIDs, beta blockers, emotions like stress, food, sodium methyl sulfate, seafood, nuts, monosodium glutamate, hormones during pregnancy or menstruation. It could be irritants like smoke, perfume, smells, and also job like wood dust, floor dust, isocyanides, animals. Clinical features: the classic symptoms are wheezing, coughing, tightness in the chest, and breathlessness. Other clinical features are cough could be worse at night or early morning, history of allergens, family history of asthma or allergens, and on examination it's a widespread audible wheeze, and all these symptoms rapidly relieved by short-acting beta agonists. Spirometry indicates obstruction if FEV over FVC less than 75%. Measurement of peak expiratory flow rate, or spirometry before and after SABA or CABA. It has characteristic improvement greater than 15% in FEV and peak expiratory flow rate. Bronchial provocation tests by inhaled histamine, methacholine, or hypertonic saline. Also, it could be helpful exercise challenge, allergy testing, and X-ray. Treatment of asthma looks quite complicated because it depends on symptoms and FEV1. So for mild cases, when symptoms quite rare, it will be just SABA or short-acting beta agonist. So, and if symptoms worse, it will be SABA and inhaled corticosteroids. If EV1 is less than 80, so it's 80 to 60, it will be SABA and also LABA, or so it's a short-acting beta agonist with long-acting beta agonist and inhaled corticosteroids. And if EV1 is less than 60, it will be again short-acting beta agonist, long-acting beta agonist, and inhaled corticosteroids, but the dosage will be more. Also, there is a disease which associated with asthma. It's an allergic bronchopulmonary aspergillosis, and it's a hypersensitivity reaction to aspergillus colonization in the bronchi. You need to always suspect this disease in patients with asthma, peripheral eosinophilia, and elevated immunoglobulin A, and bronchiectasis. Diagnosis is a skin prick test to assess for reactive to aspergillus antigens, and treatment with systemic glucocorticoids and itraconazole. Chronic obstructive pulmonary disease. It's an umbrella term for a group of progressive lung conditions including emphysema and chronic bronchitis. Factor in causation: cigarette smoking, natural fuel, wood, twigs, crop residue, airway infection like a chronic bronchitis, occupation related to silica, dust, and cadmium, familial factors, so it's a genetic predisposing like a alpha antitrypsin deficiency 1. Main symptoms are breathlessness, cough, sputum production. For advanced disease, chest tightness, wheezing, airway irritability, fatigue, anorexia, weight loss. And there is signs like tachypnea, reduced chest expansion, hyperinfiltrated lungs, hyperresonant percussion. So, and it also could be pink puffer, when person always breathless, or blue bloater, and it's edema with central cyanosis. So, diagnosis: pulmonary function tests. Spirometry is a gold standard for diagnosis, and there are 4 stages when we look at forced expiratory ratio, FER, and if it's greater than 80%, it's a mild stage. For moderate, 50 to 80, severe, 30 to 50, and very severe if it's less than 30%. Chest X-ray could be normal even with advanced disease. So also blood gases, gas transfer factors. There is a feature of COPD, it's a reduced diffusing capacity of the lung for carbon monoxide, and it's not reduced for asthma. ECG may show evidence of cor pulmonale, and cor pulmonale is a right ventricular failure. You need to suspect cor pulmonale in any patients with COPD who have some clinical features like peripheral edema, raised jugular venous pressure, loud pulmonary second heart sound, positive hepatojugular reflex. If you suspect some resistant organism, you need to do sputum culture. The only treatment proven to slow the progression of COPD is smoking cessation. And also it could be physiotherapy and breathing exercises, aerobic physical exercises program. And treatment usually looks like this. For mild cases, it's just smoking cessation and short-acting bronchodilator. Then we add long-acting bronchodilator or long-acting muscarinic antagonists. Then add corticosteroids. And if it doesn't help, it will be inhaled corticosteroids, LABA, and LAMA. It's long-acting muscarinic antagonists. Also, therapy include oxygen therapy, antibiotics, and in some cases it could be lung surgery. Cystic fibrosis is a result of defect in an ion channel protein, and this defect affects the normal transport of chloride ions, leading to decreasing sodium and water transfer, that's causing viscid secretion that affects the lungs, pancreas, and gut. General clinical features: malaise, failure to thrive, exercise intolerance, chronic respiratory problems like a cough, recurrent pneumonia, bronchiectasis, sinus tenderness and nasal polyps, gastrointestinal malabsorption, pale loose bulky stool, jaundice, meconium ileus, and infertility in males, pancreatic insufficiency, and also for this condition there is a very specific diabetes mellitus, which is not associated with diabetic ketoacidosis. Osteoporosis is seen in up to 75% of adults with cystic fibrosis. So diagnosis is screening for immunoreactive trypsinogen, sweet test, the most important one, for elevated chloride and sodium levels, DNA testing for caries. Treatment: there is no cure for cystic fibrosis, and treatment is based on correcting the nutritional deficiencies and minimizing chest infections. So it's physiotherapy for drainage of airway secretions, hypertonic saline solution, therapeutic or prophylactic antibiotics, dietary manipulation, and lung and liver transplantation. This is the end of this video. Thank you very much for watching, and see you next time.